Hi, good morning. My name is Otis Toussaint, and I am working at the Office of the Surgeon General. Today, we have a live panel discussion with 4 hospital commanders across our great U.S. Army medicine. We've got first Colonel WIRT from BAMC Hospital Command. We've got also Colonel Richard MALISH. We've also got Colonel Melissa Hoffman. And finally, we've got Colonel Scott ROOFE. So I'd like to introduce you to all of the hospital commanders, and I hope that you enjoyed today's discussion. Hi, everyone. How is everyone doing today? Good morning.
Hello.
Hey, good morning.
Doing well.
Excellent, excellent. So I'd like to go around and have everyone introduce themselves essentially to our live viewers for today's discussion. We will be discussing, I believe, certain details that everyone will enjoy sharing their information on. So first and foremost, I'd like to start with Colonel Michael WIRT.
Hello, everyone. Colonel Michael WIRT. I'm the Deputy Commanding Officer here at Brooke Army Medical Center in San Antonio. And I'm here on behalf of Brigadier General Sean Bagby and Command Sergeant Major Thurman Reynolds. I'm happy to be here, and thank you to AUSA for having us today.
Awesome. Next, we've got up Colonel Richard MALISH.
Good morning. My name is Colonel Richard MALISH. I'm the hospital commander here at DARNELL Army Medical Center. And like Colonel WIRT said, it's a great pleasure to represent the soldiers, civilians, and contractors of this great hospital. So.
Awesome, awesome. And next, we've got up Colonel Scott ROOFE.
Hey, good morning, everyone. Thanks for the opportunity to speak. I'm the acting commander at MADIGAN Army Medical Center, and I look forward to the opportunity to share our lessons learned during this entire process. Thank you.
And last but definitely not least, we've got Colonel Melissa Hoffman.
Good morning from Fort Benning. This is Colonel Melissa Hoffman. I'm the hospital commander here at Martin Army Community Hospital. Excited to be a part of this great group this morning, and excited to talk about our expansion plan as well as our testing capabilities here as well. So good morning, everyone.
Awesome, awesome. So I appreciate everyone taking their time to come out and actually share the good information from each hospital commands. First and foremost, we've got the first person to essentially share his information will be Colonel WIRT. So, sir, we've got some slides, I believe, for your presentation. And as we prepare those slides, I'm sure that you're looking forward to sharing this good information for us. So, first and foremost, we've got Colonel Michael WIRT.
Thank you very much. We can actually go to the next slide, please.
Mm-hmm.
And this is the outline for our presentation today. I'm going to discuss how we protected our facility, enabling both our staff to treat the COVID patients while also maintaining our level 1 trauma mission and our ability to perform extracorporeal membrane oxygenation, or ECMO, which is essentially a heart-lung bypass procedure. ECMO often serves as the last line of defense and treatment for patients suffering from severe COVID-related lung injury. Next slide, please.
Mm-hmm.
This is the BAMC mission and vision. I'll just pause just a second. Next slide, please.
Mm-hmm.
I'd like to introduce you to BAMC in a little bit. We're a very large facility, or a complex medical center of over 8,500 active duty federal, civilian, and contract staff. Our active duty team is comprised predominantly of Army and Air Force service members, with additional contributions from both Navy and Public Health Service. We provide a full range of primary care and subspecialty services and conduct approximately 27% of the Air Force graduate medical education and 20% of the Army graduate medical education on site. We have several unique capabilities, to include being the only level 1 trauma center in the Department of Defense. Again, we conduct the special extracorporeal membrane oxygenation, or ECMO, procedures. We house the U.S. Army Institute of Surgical Research Burn Center, and we support them with logistics. And we have the longest accredited cancer center and bone marrow transplant autologous bone marrow transplant capability. So a couple of those areas, both the Institute of Surgical Research Burn Center, the bone marrow transplant, and cancer patients were ones we had to be particularly careful with in making sure that as we brought and treated patients with COVID, that we isolated those areas to protect those patients. We have 24 ORs in 2 OR areas, one in our main tower and one in our older BAMC building. And we were able to segregate those 2 OR systems where we closed the 12 ORs in the older building while we maintained the remaining ORs in our consolidated tower. And by doing this, we were able to preserve our trauma mission and also reduce the utilization of personal protective equipment.
Hey,
We
sir,
have over
just
400.
just to quickly interrupt, sir, I'm going to go ahead and put this on full screen so that people could see it a little bit more detail on the screen.
Sure.
So here we go.
All right. We have over 400 beds, including 66 ICU beds in over 3 million square feet of facility. So we're quite a large facility, complex logistics operation. Next slide, please. So to kick off the COVID discussion, we'd like to open with a short video.
We're moving into uncharted territory.
Millions of students will now have to stay home.
The financial markets in free fall.
A nation on edge as efforts to contain a global pandemic.
New coronavirus hotspots are
calling this dangerous and distressing.
Coronavirus cases continues to rise across Texas.
In the total number of coronavirus cases in Bexar County.
We need everyone's attention on the things that we must do to get a handle.
Our hospital capacity could run out.
All right.
So that was a scene setter just to give you an opportunity to kind of look at what we've done in a nutshell in the 30-second video. And now we can discuss this a little bit more in detail. If we go to the next slide, please. So our challenge was really to maintain access to safe, high-quality care while responding to local, regional, and national stakeholder requirements. Some of the key facts that we had to deal with were the mobilization of both Army and Air Force healthcare teammates, which reduced our capacity to care for patients on site. Now, we had to then look for agile response solutions, which included looking across the installation here at Fort Sam and optimizing medical providers from different units resident Fort Sam Houston, repurposing some of our outpatient staff to inpatient staff, optimizing our market capability using both Air Force and Army active duty that are stationed at local Air Force facilities, as well as looking at the Medical Center of Excellence and their vast medical capability and bringing some of those providers back over to BAMC to help us complete our mission. Some of the other facts were we needed to sustain our critical, unique missions of trauma, burn, and ECMO. And we also had to always be ready to support a national contingency operation. So we assumed that our patient census is going to increase to an unknown number. Some of our staff may become COVID positive, both from either contracting COVID from within the community or potentially contracting COVID within the facility. And lastly, we'll encounter logistics challenges, and especially for personal protective equipment, specialized care for patients on ventilators, and other areas COVID specific that we would be concerned about. We had to assume that our supply line would not always be fluid as we could expect during normal operations. Next slide, please. So we identified some key lines of effort. One was to maximize inpatient bed capacity and capability. So this was a very deliberate planning operation, which we conducted an operations order. So we planned this out in detail. We designed bed space for both COVID areas and non-COVID areas. We repurposed and planned for other areas within the hospital to be able to accommodate patient care. So if we had an area that was a former ward that was turned into a clinic, then we repurposed that, moved the clinic back out, reestablished it as ward space, so we would be able to house patients there. We also looked at areas such as operating rooms or our additional recovery room in the area where the operating rooms were not being used. And we repurposed those so we could add additional ICU space if required. We also developed a conditions-based expansion matrix. So we would look at certain conditions, like how full a ward would be, and at a certain trigger point, then we would expand that ward into another area for patient care. And the execution matrix that we would put together for that would have these triggers so that at a certain point, then the logistics team would know that they would need to prepare that. The pharmacy team would know that they would need to stock the medications on that ward. The nursing staff would know that they'd need to go and train on that unit and prepare to open it and make sure that all the quality and safety measures were ready. And as we would do that in advance at each stage so that we were ready to open those wards as we needed it as conditions dictated. Another area that we reduced our numbers of operations that were both elective, our procedures that were elective, and by decreasing elective surgery cases, we were able to reduce our census so that we could repurpose staff to prioritize for inpatient care. The next slide, please.
Mm-hmm.
Now, we wanted to ensure safe, high-quality care for all of our patients and staff. So some of the things we had to do was isolate the hospital so that we would not bring COVID from the community into the hospital inadvertently. So by doing so, we established a restrictive visitation policy, very consistent with what was happening in the San Antonio community. We reduced our hospital entrances to 3, and we implemented screening protocols at each entrance. And then we maximized telework. So instead of having all of our patients and all of our staff coming into the hospital for all the normal services, we really reduced the number of services and the number of staff coming in by optimizing telework, by optimizing virtual health, and then by establishing both a drive-through pharmacy and then an external screening and testing operation for COVID that was outside of our building. Lastly, we had to increase our lab capacity and capability, and I'll discuss that in greater detail in several slides upcoming. Next slide, please. So to set conditions, we called this kind of Fortress BAMC, and we did that for a reason, as we needed to protect our staff and protect the building from bringing COVID in inadvertently, and then causing many of our staff then to go on isolation and not being able to provide the care necessary for our beneficiaries in the community. So the BAMC drive-through operations were one of our biggest areas of success, where our curbside pharmacy in 3 months saw 162,083 prescriptions and over 89,000 vehicles. That also occurred at Lackland and at Randolph Air Force bases in our local community, where they established drive-through curbside pharmacies as well. Additionally, we tested and screened over 60,000 patients and beneficiaries outside of our facility in essentially a combat support hospital, or a tent city that we set up, where we could do all of this testing outside, again, mitigating risk and bringing less people into our building at a time of high uncertainty during the first few months of the COVID epidemic. And lastly, again, optimizing virtual health allowed us to maintain access to care without having to bring patients for face-to-face appointments. And actually, both the virtual health and the drive-through pharmacy obtained great patient satisfaction across the entire San Antonio market. And we were able to reduce the utilization of personal protective equipment, PPE, through these different types of initiatives. And by doing that, we were able to position ourselves to address any large increases in inpatient volume in our intensive care units or on our wards, because our supply line, as it was nationally, was uncertain initially. Next slide, please. So I'd like to go into a little bit more on the laboratory preparation. First, we established an initial capability in late February utilizing a CDC-developed test, which could run on one lab instrument with a throughput of about 20 tests per day. So that wasn't a lot. Now, if you look at the left side of the slide, at the bottom left, you'll see some black and yellow graphics. That really represents the black is the testing capability. So that's our capacity. That's how much we can do. And the yellow was the requirement. So we were able to match initially we had very low COVID numbers. So we were able to match a requirement with that capability, but we knew that we had to ramp up our capability for testing as our COVID numbers increased in San Antonio. So our first test that we performed was on 13 March. And moving forward from there, we were able to increase our testing capability and capacity to about 160 tests per day into April and toward the end of April. Next slide, please. In addition to standard testing, we acquired rapid testing capability in April, which helped us disposition emergency department patients as well as evaluate inpatients. And then we segregated and trained our workforce. So as we had more laboratory members trained to run these instruments, we were able to segregate teams and put them into small pods or teams that if one of our service members or employees were to test positive, we would have to isolate that team, and we didn't want to lose our complete lab capability in one shot. So we had to segregate teams. We did that throughout the facility with other services as well, to include radiology. Next slide, please. By summer, we had a second spike, but we were fortunate to have high volume testing capability by then, with the potential to test up to 1,000 tests per day. And that really helped us be prepared to address the summer spike. In addition, we were able to test both symptomatic and asymptomatic, do some asymptomatic screening for some of our more vulnerable populations. Next slide, please. And the current state, as you said, we've tested more than 60,000 beneficiaries to date, and we've been able to match our testing capacity for the requirement throughout, without any really deficits or inability to perform those tests, other than challenges from logistics. But we've been able to also establish pre-op testing. So before patients go to the operating room to get tested, also we test all of our admissions. Next slide, please. So for our surgical strategy, we curtailed all of our elective surgeries to preserve the PPE. We attempted to address caseload backlog. So as we curtailed those elective surgeries in early March, then in May, we tried to readdress some of those surgical backlog, and some of the patients which would have transitioned from an elective case to a less elective case, we would prioritize those. But unfortunately, we had to revert back to kind of a more of a pure urgent case only foothold in July and August, or early August, due to a second COVID spike, really from June through July. And then by mid-August, we re-established our normal surgical operational tempo, and we reduced our elective surgery wait list by about 25%. In the midst of this, we were compensating for an increase in trauma throughout the city, and we completed 7 weeks of trauma transfer divert in support of San Antonio and part of our partnership with both the University Hospital System and the Southwest Texas Regional Advisory Council for Trauma. So we saw about a 40% increase in trauma volume during that 7-week period. And we were able to do that through our secretarial designee program. In addition, we saw and helped address the requirement for the extracorporeal membrane oxygenation, or ECMO, support to the city of San Antonio through an Air Force secretarial designee program. So we never had to go on trauma divert. We were able to support the city, maintain our level 1 trauma mission, and accommodate all of the patient volume that we saw throughout both our early COVID spike in March and then a second spike in June and July. Next slide, please. Our medical strategy was to establish a multidisciplinary team of experts to advise the command on both testing and on all of our different patient care efforts. We wanted to establish and use evidence-based practice and make sure that what we were doing provided the highest quality and safe patient care. We transitioned almost all of our primary and specialty care and the medical services to virtual, some up to 85%. And we initiated a nurse information line to reduce the number of patients going into our COVID screening areas if they were worried well, and they could be reassured over the phone by a qualified and trained nurse. We initiated behavioral health support lines to optimize access for those who did not need face-to-face behavioral health care. And we also optimized inpatient care teams. So again, we could segregate teams up initially, at least, such that if one team had a COVID positive staff member, the entire medical service wouldn't be in trouble. We could isolate and segregate those individuals, but we still have enough inpatient teams to care for our patients. And lastly, we had a lot of recommendations across the city of San Antonio as far as how we should implement and prioritize asymptomatic screening, and this medical team of experts helped inform that. Next slide, please. So in summary, our agility, conditions-based expansion and contraction, development of an execution matrix to signal our logistics requirements in open and closed wards, ICUs, and alternative spaces, and our multidisciplinary approach leveraging telehealth, telework, and external operations such as testing and screening, and our drive-through pharmacy all helped us maintain a safe working environment for our patients and staff while addressing all the requirements of testing, screening, and addressing our COVID dilemma here at Brooke Army Medical Center. So subject to questions, thank you very much for your time and attention.
Well, sir, thank you for your presentation. I do believe we do have a couple questions for the presentation, and I'll go ahead and just post it on screen. And here we go. The first question is, sir, looking back the past few months, what are some of the most significant lessons learned?
Oh, I think the best thing that we did early was protect the organization, and that was leveraging our telework, optimizing and really encouraging telehealth and virtual medicine. And the drive-through pharmacy, again, a huge success in achieving our highest patient satisfaction numbers in years, just by providing that service. But what it really did for us is reduce foot traffic within our facility. Another thing that we did was we credentialed and privileged providers. We pre-screened staff on Fort Sam Houston as we saw this coming, so that we could quickly move them. Actually, we oriented them to the hospital. We did orientation weeks. This is before we required their help, but we were ready to then bring them in and assimilate them into the organization, knowing that we were going to have stress from the outside requirements. The Air Force has special teams capable of, moving patients from one area to another. Some of those teams were mobilized, and taken out of our facility. And those are critical care nursing staff that we knew we were going to need in ICU areas. So we had to look and essentially harvest from Fort Sam Houston as much help as we could get so we could accommodate losing those staff but still provide the patient care mission. And then projecting and being able to help our logistics team know what we were going to do and need next. And if we could pre-plan that for them and kind of give them a 3-day heads up, then we were able to transition wards and ICU spaces pretty seamlessly without causing a lot of stress and causing some real problems for both the nursing staff and the logistics staff. So we preserved PPE. We never got ourselves into a significant problem. I think by pushing people and services as much as we could externally to the main hospital system. Over.
Awesome. We got another question, sir. Just one more. The second question is, what aspects of protocol have been put in place to deal with the pandemic are likely to stay in place?
I've got to say virtual health, is the number one. We probably would have rolled this out much slower had it not been from the pandemic, but it was a forcing function that got both us and our patients used to doing it. And it has been wonderful. I think we've improved our access to care. We've seen so many different things that we can use virtual health for now that I think are beneficial for both our patients and saving them time, saving them driving in, saving them having to park. In addition, it protects our staff from just decreasing the congestion within the hospital. So number one, virtual health. Two, probably leveraging telework. There's more telework to be had than I think we did up front. So we're assessing that now, and we're seeing what jobs are most amenable to telework, what jobs maybe we didn't get as much out of that we have to bring back. But that's an ongoing assessment. But I think that's been very helpful too. And then that helps us re-look at how we utilize space within the facility. So telework and virtual health, I think, are our two big ones.
Awesome. Awesome. Sir, we really appreciate you just sharing the good information for us. And we look forward to hearing from our other panelists. I believe we have Colonel MALISH next from the MADIGAN Army Center. Sir, you're up.
Yeah, hey, this is Colonel MALISH, and I'm not from Madigan. I'm from Darnell, but it's a beautiful place. I apologize. I did my internship there years ago, but
my bad. Good catch, sir. Good catch.
No problem. But what I want to begin by saying, as you pull up the slides, is that that what we did here at Darnell was really a team effort, and couldn't have done it without our teammates on Fort Hood, the 3 Corps leadership, our teammates out in the community as well. And so while I'm presenting on behalf of BAMC, I'm really a representative of this great leadership team that we have here. So second slide, please.
Okay, let's go ahead and I'll put it on full screen.
Yeah, thank you, sir. Very similar to BAMC's presentation, I'm just going to start with a quick overview of BAMC. And at BAMC, we have 100,000 beneficiaries. And to make it simple, I'll just break them down into thirds. So about third active duty soldiers, 1/3 family members, and 1/3 retirees. And we're basically we're a med-cen with residency training in family medicine, emergency department, and psychiatry. But much of what we do is deliver babies. I bet you we're one of the biggest baby delivery factories in the Army. We have an 8-bed OR as well as an ICU. We have a behavioral health unit, et cetera. But what I'd like to bring your attention to is the column there, or the box to the left, which is the description of our primary care. And if we go on the next slide, I'll go a little bit into more detail about our primary care. The primary care is the sort of energy generator of our health system. It's where the majority of our patients get their care. And many patients will never even have to come into the hospital for any reason whatsoever. They'll just get all of their care at their primary care center. And what you can see here is that it's a dispersed system. In yellow, those are community-based homes. Those are homes that are taking care of our family members and our retirees. Those are all out in the communities. And then in the green, you can see those are soldier-centered homes. And that's where all of our soldiers get their primary care. And in the middle there with the symbol care and concern, that is BAMC. And again, that's where we handle referrals, take care of surgeries. We're the tertiary care center and really a readiness generator because we do create a lot of the medical force in terms of medics and those primary care specialties that I mentioned earlier. And we support 3 Corps and Fort Hood, and many of our providers at those green nodes there, those soldier-centered homes, are actually not BAMCs, but they belong to 3 Corps, 1st Cav Division, and the FORCECOM unit. So we're all linked as a team in our efforts. One thing I would like to mention, and I think Colonel Wirt started to talk about it, we had begun an initiative to turn our primary care homes into ones that weren't tethered so much to appointments. In other words, we were trying to create urgent care centers. We were doing this by offloading a lot of primary care into the virtual arena, thereby creating availability to see patients. So you'll see this term quick clinic. This stands for quality, urgent, internet, and phone care. And we'd started a conversion process in which we had converted one of our primary care homes into this model. It's a value-based model, and it's much better for patients and providers alike. Next slide, please. This is going to be the agenda, and we can just move into the next slide. One thing we did right away at the very beginning as a sort of a stage setter was we stood up our emergency operations center. And this was no small affair. We in fact expanded our space that we had used for our previous trials of our EOC, and we expanded and we created a very large operation co-located with the 24/7 hotline. That was 4 operators that were there during the entire time, and they were not only answering questions, but they were collecting intel, seeing where the gaps were sort of in our messaging campaign. With this EOC, we were in communication with the 6 hospitals that surround us, 6 civilian hospitals, constant communications, because as Colonel Wirt mentioned, we're part of a network, and where we might be short on beds, if we're able to borrow beds in our neighbor hospitals, it's a good thing. So I really became great friends with the 6 CEOs, and as well as mentioned earlier, we were in constant contact with Fort Hood and 3 Corps. In terms of organization, we just took the Army's warfighting functions, and you can see how those are listed there under number 3 on the left. This is how we batched sort of our efforts: intelligence, fires, movement and maneuver, sustainment, protection, command and control. And those worked well for not only contact with the enemy, but contact with the COVID-19 virus. And you'll see as we move through these slides where I've highlighted which warfighting function we used, how we batched sort of our efforts. And so the next slide is where we began. And what we did, if you go to the next slide, sir, is you'll see here that in the intelligence warfighting function, again, we're trying to understand the movement of the virus in our operational environment. And so we took online software and we started doing our own curves. And these were curves that were based on our demographics. So we plugged in our patients, remember 1/3 active duty, 1/3 family members, 1/3 retirees, and their ages and their disease types. And then we programmed in also our specific hospital capabilities. And we wanted to know where we would be, where our threshold would be broken, and we wouldn't have enough beds for our patients. And so we did we ran a couple of different models. But the one that we thought we could survive was a transmission rate of 1.5. And so that's where we began with our information campaign, which you'll see on the next page. This was key because not only did we prepare the hospital, but we had to make sure that our teammates, and our teammates, by the way, include all of the communities around us in Queen, Copper Cove, Harper Heights, et cetera, were aware of the risk of the transmission of the virus in so much that it could potentially overwhelm the medical system. But again, these are curves, but they're specific, customized to our patient population and to our hospital. And we'll see more of that later on in the brief. Next slide, please. So these curves concerned us, and we got after it by a public health campaign, putting up signage all over the hospital. As mentioned, I met with the CEOs of the 6 regional hospitals, and we signed a letter together talking about the things that have become common, sort of vernacular about social distancing, et cetera. We did this very, very early on, and we got these letters out to the community. And then you can see we were partnered 100% with a 3-Corps leadership, Fort Hood, communicating over town halls, etc., press releases. And then really, I think what helped the most was working with the 3-Corps leadership to implement policy. And we were quick to sort of move to this, these protective measures in terms of social distancing with minimal manning, etc. But this was through our 3-Corps headquarters leadership. And I think this was had a major impact on the spread and flattened the curve, quite frankly, and led to our success here at BAMC. So the first thing we did, and this we sort of batched in the FIRE's warfighting function to get the word out to influence the spread of the coronavirus in our population. Next slide, please. So this was our bed plan, and on the left you can see we have in yellow, these are specialized beds. They can't be converted to COVID-19 bed. And you see L&D, that's labor and delivery, MBU, that's mother baby unit, NICU is our neonate ICU, and then IDH is internal behavioral health. So all those beds were could not be converted into COVID-19. And the green and red on the left, you can see we had dirty beds and clean beds, but a small COVID-19 capacity. And what we were able to do is expand quite significantly. You can see all the numbers there. Remained in yellow, and this is off to the right now. You can see our specialty beds, we retained them, but we converted a number of our same-day surgery beds and PACU ventilators into makeshift ICUs, and then we expanded our ICU. We had an additional ward that we opened, and those are the blue beds, and we double bedded those rooms as well. And then just like BAMC, we borrowed from our operational neighbors a combat support hospital, basically a Role 2, not the entire hospital, but the area support medical company, which offered a 40-bed capacity, and we co-located them with us, and that expanded our capacity quite a bit as well. But this was these were our initial plans, and I'll move on to the next slide. One thing that we recognized right away was we weren't going to have the manpower to man all those beds. And even more of concern was that we didn't have the necessary specialties to man them. So what we did was similar to what the BAMC did, and that was we took our internists and we made sure that they were capable of being intensivists. We took our family medicine hospitalists and made sure they were capable of doing ICU work. And then we took our outpatient docs and got them trained up on being inpatient docs. And we had a 3-phased training process that wasn't as easy as you might think, because this was back in a time in which little was known about COVID-19 and how to best treat it. So we're taking real-time medical evidence and teaching our providers that, as for example, we learned about remdesivir, proning, et cetera. We're also very, very good at getting the rotating beds for proning, et cetera. But we trained all of these providers in a 3-phased approach, and there was a lot of them, in the hundreds. And then we returned them back to their place of duty. The 3rd phase was hands-on training with the simulation lab in our ICU, working with the proning beds, et cetera, working with ventilators. And then again, once they passed all their check marks, once they were deemed competent, we returned them back to their place of duty. Next slide, please. And this is a key and important piece of information. BAMC had one. This is our decision support matrix, a key planning tool. So this is our curve. You'll see 2 curves here. These are the curves in the background. The one that looks like a mountain is a peak, and then there's a red one. Those are numbers, patient numbers, representing the census of our ward. That's the big mountain one, or the ICU. That's the one in the red. Based on our projections, we thought that we were going to follow one of these tracks. And as we did, we would cross through phase lines. And the phase lines are those vertical lines, and you can see what they were. So as we got closer to a phase line, this is moving from time from left to right. And I'll just start with the red one. I can't really see it, but it says enough COVID-19 patients to open the COVID-19 ward. So, so at that point, we knew we had a decision to make, and so we moved to the left on the curve before that happened and created a decision point and created standards and requirements to talk through that. And so each major phase change had a decision point that was before we reached that phase line, and it was informed by a number of different things. This was key because it made sure that we didn't make decisions ahead of the time we needed to make decisions. This kept us well balanced in our approach and kept us disciplined so that we didn't, for example, bring providers in from the field too early, who by the way, were providing a mission the entire time, or commit too much of our PPE to one location, et cetera. Very, very similar to what BAMC did. But it was key that we didn't get ahead of ourselves and sort of fall down, into the hospital here and stop providing care to our patients before we were required to do this. And this decision support matrix is what allowed us to remain balanced and disciplined throughout our entire response. Next slide, please. These were some of the actual changes we made. You'll see there's a triangle on this map, overlaid on this map. We did two things. We did a respiratory drive-through, 4-lane drive-through that was extremely high capacity, and this continues till today. And that's where we saw all of our patients who thought they might have COVID-19 or were expressing symptoms but weren't terribly sick. They would come through and they'd have a medical encounter in their car, and then we would test them on the spot. And then this was facilitated by the Area Support Medical Company, which was out in our garage. Both of these entities were out in our garage, and they continue to be there. Actually, the Area Support Medical Company has been redeployed, but these were facilities that made sure that we could take care of COVID-19, the vast masses of COVID-19 patients, without them having to come into our hospital. And it was convenient for them, and it was good for the hospital as well. Next slide, please. And I'll just, this is our emergency room, and I'll just break it down into a couple of points. You can see in the blue out there, these are our respiratory drive-through. This was all integrated into our hospital workflow. So respiratory drive-through and our Area Support Medical Company, that 40-bed hospital, both of those were equipped with command nodes. In other words, they were making decisions, triage decisions about where patients went. They then would go to what we call the ED quarterback, and that position enabled us to offload the ER if we needed to. In other words, if patients had symptoms that were not concerning for COVID-19, we could return them to their primary care home and not have them go through the ER. Keep them out of our ER, keep them safe from potentially contracting COVID-19 within our ER. But we had these decision nodes, and these were dispersing patients to where they could best be seen, back to their primary care homes, et cetera. Which, by the way, enforced us to ensure that there was testing and screening at all of these primary care homes. And then within the ER, we had a triage nurse as well. And that triage nurse would either send them through our COVID-19 pathway or our normal ER pathway. Next slide, please. Okay, I'm just going to end by the sixth bullet, which says seize the initiatives in the COVID-19 white space. And that's really what I think we learned the most from. So if you go to the next slide, this was our philosophy. Next slide, please. We wanted to do as little reconfiguration as possible. We wanted to keep our healthcare system, back one, please, intact. Back one slide. As much as possible. We didn't want to centralize testing. We didn't want to centralize screening. We didn't want to centralize sort of access to the system. So all of our primary care centers there never closed. They never closed their doors. They did become equipped with the capacity and the protective measures to be able to take care of COVID on site. And that's and that was aided by our decision support matrix. But that enabled us to seize opportunities afforded by the crisis. And I'll go on to the next one. The next slide will show you what these opportunities were. Okay, this slide is just the amount of patients that we are seeing in our system every day, and it goes over time. And you can see the black colored number column there is how many patients are being seen face to face. The gray column on top of it, and I'm off to the left, is how many patients are taken care of with telephone consultations. You can see that in the thick of COVID-19, our throughput was decreased quite almost in half. It's a substantial decrease in patients, and most of that is from patients no longer coming in face-to-face, which, by the way, was a mandate. We were told to minimize routine care, and we did. And so our face-to-face appointments go down. That creates what we call COVID-19 white space, and that's the medical system that has workers that are available to do more, because we're not seeing the day-to-day face-to-face patients. And they're all at their primary care homes, by the way. And you can see something springs and grows out of that. That's those white spaces, and that's our virtual health process. Every single one of our homes converted to virtual health. Our call center converted to virtual health. And by the end, by where we are right now, more of our care is provided by virtual health than what we're seeing face-to-face. And we're by far the #1 hospital in the DoD, with more than twice the amount of our nearest competitor in terms of doing virtual health. And again, this is primary care virtual health. This is care that can be done with information exchange without requiring hands-on. And we really seized the opportunity. And it wasn't easy, by the way, because we had to reconfigure a lot of our workflows and get a lot of the software and hardware in place. And that's what took us a little bit of time to get it going. But we seized the opportunity, and now we will be a healthcare system that handles these low acuity problems with virtual care from now throughout. Next slide, please. I'm just going to talk about a second opportunity that came out of COVID-19. And that is this. We had white space. These were providers who weren't seeing patients. They had been trained to go to the hospital and take care of COVID-19, but we never reached one of those trigger points or decision points. And so we became concerned about two things. And these were patients with chronic disorders who were, because of COVID and the instructions we were giving them, were not accessing healthcare. So we did an outreach to them. We called our 2006 sickest patients. And by that, I mean patients with chronic disorders, cardiovascular disease, pulmonary disease, diabetes, et cetera, and made sure that they had what they needed. And this was to prevent a second wave of mortality and morbidity. And then once we had reached out to them, we said, okay, what are the other things that might go wrong from an entire healthcare system pivoting to COVID-19? And what we came back with was cancer screenings and a third wave of morbidity and mortality, and off in the future, because patients had weighed the risk of COVID-19 higher than the risk of cancer screen, and we got after it. So we moved out and said, hey, if you need your a pap smear, we're going to get you. If you need a mammogram, we're going to get after it. And we moved up we had a small amount of backlog, which is not unusual for a hospital. But we moved through those backlogs and are now in the top 10% in the country in terms of our cancer screens. And we're going to continue this as well. Next slide, please. And I'm going to finish with this final slide. Our primary care homes, they're dispersed. They are now operating with virtual health for the majority of their patient contacts. If a patient needs to be seen, because we're handling much of what they need to be seen for with virtual, we now have created space to bring patients in for urgent care visits. So we have urgent care. We created that urgent care by transitioning face-to-face into virtual. And we're obsessed with quality, and that quality is manifested by those quality metrics and those cancer screens that I just mentioned. So this is a new paradigm of care, and we were able to go from one clinic to 5 of our community-based homes, all operating under this system of care, because we were in fact told to do so by not only by the rules of COVID-19, but by both the state of Texas and the AMED and Army, but also because we were going that way anyway. So that's my presentation in a nutshell. I'm happy to take any questions.
Actually, sir, we do have a few questions. And I've actually got a question also for a prior presenter, Colonel WIRT. Sir, so before we get into the presentations to be given by Colonel ROOFE and Colonel HOFFMAN, we'd like to go ahead and address these questions so that it could still stay fresh in our minds. So the first question, this will be going to Colonel WIRT. Sir, the question comes from a Brent Daniel. The question is, what types of healthcare cannot be accomplished virtually, and how do we address those areas which cannot be accomplished virtually?
That's a great question. Well, you know, I'd say anything requiring a procedure. So as we kind of hinted at with cancer screening, colonoscopies, it's critically important to do those. Mammography, they have to both be done in person. So we're working on ways to ensure that we get back in sync with both colonoscopy and mammography, the backlog that we sustained during the initial shutdown of the facility. Chemotherapy, we had to preserve chemotherapy throughout. You can't do that virtually, so we had to bring patients in. Immunizations, we had to carefully bring in all of our pediatric patients who require routine immunizations. And then high-risk behavioral health. You know, we certainly don't want to do those virtually. If we need to bring them in, assess the patient, be there face-to-face. So those are some of the areas where we would want to still maintain a face-to-face care. And also, just to note, when we do this virtual healthcare, we're providing the care that the patient needs. But if there's something that's identified during one of those virtual health appointments, then we schedule an in-person appointment. So we assess each patient individually, and then if they need to be brought in, we bring them in. We'll schedule that. But if it can be taken care of virtually, and we don't have to have the patient come in, you know, we obviously prefer that.
Awesome.
And the
So,
patients
sir,
are preferring that as well.
Thank you. That was an excellent question. We've also got some comments coming in, actually. Also, sir, and I think you're going to like this one. This comment comes in from Miss Ashley Faye Sir Johnson. She says, Colonel WIRT is an amazing commander. My husband served with him at the ISR. And, you know, comments like these kind of just put a good smile on our faces. Obviously, it's doing with you as well. And I think this comment here, the next one, can be done. Essentially, this is a shout out to every commander that we have here. And this comment comes in from Miss Marie. She says, the greatest action for taking care of people's health is done by U.S. Army. You are great in all. So, you know, just a good compliment to every commander we have here. So the next three questions I have, these will be directly to you, Colonel Malish. And so the first question comes in from Miss Mary Johnson. I believe this is my battalion XO, Major Mary Johnson. And she asks, what challenges did you face during this time? Access to care and PPE.
Thank you, and thank you for the question. Actually, those were significant concerns, the PPE specifically, but because of the great supply chain logistics that our Army has for us, we really never ran out of supply of anything, not even of our testing supplies. I'll tell you what the biggest challenge we faced during this time, and that was that this new normal was supposed to happen sort of unconsciously, or it was supposed to be a smooth sailing. And that, I don't think, is actually true. And by the new normal, I mean conversion to virtual health, getting after cancer screening, et cetera. That actually required quite a bit of leadership from the command team, et cetera. And a lot of it had to do with the fact that while we know that we need to sort of transition and jump forward into the 20th century, 21st century with technology, we actually didn't have the technology in place to get after virtual health. So bringing all of this equipment, getting all these workflows established, training all of our providers and our patients, by the way, on the use of virtual health was one of the main challenges. I do want to answer one of the questions that was given to Colonel WIRT, because the question was what can be seen, what needs to be seen in face-to-face, and that is almost anything in which you're not doing well. However, a majority of our healthcare before this paradigm was not for that. It was for routine matters such as follow-up, discussing referrals, discussing labs, discussing x-rays, discussing radiographs, just following up, talking about referrals, etc. That is a large amount of work that can be transitioned straight into the virtual world. And prior to this, because of the way our system was erected, we were bringing all of those patients in. They were going through our waiting room, through our parking lot, through our front desk, into an exam room, etc. And then we were just having conversations with them. And this is not just Army medicine. This is something that's well known in American healthcare. And so all that information exchange should be done virtually, and it's quite a lot of what we do. And again, that opens up our doors to take care of those patients who need to be seen because they're not doing well, they're feeling sick, you know, they have an injury, et cetera. Okay, I'll stand by for the next question.
Awesome, awesome. Maybe these two questions, I think, well, could be either Colonel Wirt or yourself could answer these next two questions. So the first question is, will you continue virtual health in the future? Obviously, you know, Colonel Wirt, you kind of spoke on that. That's going to be the normal, but either one of you can expand on that. Oh, I think you're muted, Colonel Wirt.
Yeah, from Colonel Kradamsky, there's absolutely no plan to go back. In fact, I've understood that the Army has recently acquired a new virtual health platform, which was one that we used here, a version of it in a couple of our clinics, which we're very happy with. That our providers are very happy with it, as well as our patients. So from my knowledge, the AMED Office of the Surgeon General is moving forward with a new virtual health platform, and it's a very good one. Over.
All right, and then the last question is, and I think Colonel Wirt, you could take this one. It says, what do you do specific for your pregnancy population, labor delivery protocols?
Any mechanism to provide care for COVID?
So what we did is, one, we initially isolated the entrance for L&D so that entrance was specifically for our patients who would come in, could go to L&D clinic or be brought up to the labor deck if required. We also established a protocol, so if we did have a patient who was COVID positive and pregnant and requiring delivery, we had a special OB operating area for delivery in that area, and we could segregate that patient. So we specifically looked out for them, planned for it, and tried to protect both the patient and both patients, actually, the baby and the mom.
Thank you very much for the answer, sir. And so I believe we have next on the agenda Colonel Scott, and I apologize for mixing up yourself and Colonel MALISH, but you understand we sometimes make mistakes, especially during live streams, but I'm sure we're going to knock it out the park with you, sir. Looking forward to hearing your side of your presentation, sir.
Now, thank you all for the opportunity to be here. I will say that I was at Kardamsey many years ago, and so I'm happy to say that they're one of my colleagues, and I had a great experience there. I do appreciate the opportunity to share some of our lessons learned during this COVID pandemic. I do have a video, but before we show the video, I'd just like to make a few comments. Washington State was the first in the nation to have COVID patients, and we recognized pretty quickly that we were going to have to expand capacity to be able to meet the potential demand. We primarily focused our efforts first on expanding capacity, repurposing a number of areas for potential COVID patients, and that includes expanding our ICUs, reclaiming some areas that really had shifted away from patient care focus. So over the years, like a lot of our medicines, the ICU area had contracted to some degree. So we were able to expand those into those naturally existing areas that were previously dedicated when the facility was built to house intensive care patients. We also created a plan and set up our PACU in order to expand a number of beds into that area, while stopping elective procedures has already been alluded to. One of our wins in this area was really what we talked about in virtual health. So our focus was to try to shift a number of patients outside of the facility, but continue to provide access to care, and that includes leveraging virtual health, as has already been mentioned, but then looking at all of our workflows, moving our pharmacy to our 2 drive-through lanes. And that was not without difficulty, but it was a way to inform how we're going to move and do business in the future. Another was just looking at our areas that have been utilized for office space. I think we're not alone in the fact that a lot of our areas in the facility that were previously patient bed space was reclaimed into office space, and we were able to reverse that and clear those out pretty quickly. In addition, we dedicated certain ward spaces to primarily to clinical, or rather care for patients who were non-COVID, and then dedicated ward space just for our COVID patients, and being able, with the capability to be able to expand into some of those other areas should we need to in terms of the numbers of patients. We also, on one of our floors, cleared out a number of offices. Our logistics team was phenomenal in that aspect. Cleared out a number of offices for space for potential patients, but then also we were able to use that as a dual purpose. We used those areas not only to be prepared to put patients in, but we used it for our contingency training. So utilizing what we would perceive as our nurse and physician extenders, those providers that don't normally take care of sick patients in the hospital. We trained our outpatient nurses, our specialty providers, and a number of other folks around the footprint in those reclaimed areas in order to provide a space for training. Now, none of this could have been possible without leveraging our partnerships in the area, and that includes not only our operational partners like the 47th Cash and the 62nd Medical Brigade. In fact, we were going to use their beds for our expansion capability, but we quickly realized they would be needed around the nation for other support. So what we ended up doing was leveraging the market. So our partners in the Puget Sound EMISM, like at Naval Hospital Bremerton and Oak Harbor, Bremerton came online, sent us some beds rather immediately. We were able to set those up as well. Another lesson learned during this time period was communication, and not only communication between the stakeholders, our FORCECOM colleagues, the First Corps, as well as our partners throughout the market and our operational colleagues, but also in the civilian arena. So public health and preventive medicine, we've been in lockstep with them since the very beginning. And then the opportunity to communicate with our beneficiaries, leveraging Facebook. Our PAO team created over 70 videos to be able to communicate with the rest of the team. As has already been mentioned, there were a number of efforts that we needed to continue in terms of patient care, not only the emergent and urgent care, but also those things like cancer screening and the like. And then in addition to that, we have a very robust labor and delivery section here, much like our colleagues down at DARNELL. And those 150 births on average that we have historically continued unabated during that time. So we needed to create sort of creative ways to be able to make sure that we take care of those patients in a safe way. So I'll stop right there, and if we could watch the video, and then if there are any questions or other comments afterwards, we'll address those.
All right, let's get into the video.
In January of this year, the first patient known to have COVID-19 in North America admitted to a hospital just north of Seattle. In early March, Madigan Army Medical Center admitted its first patient for complications associated with COVID-19. To our knowledge, Madigan was the first CONUS-based installation exposed to COVID-19. In the early days, Seattle was the first metropolitan epicenter for COVID-19 outbreaks in the United States. Madigan staff met the unknowns of the disease and challenges of healthcare delivery posed by this pandemic, as it always does, with rapid innovation. Madigan staff responded early and aggressively with support from Joint Base Lewis McChord, Regional Health Command Pacific, and in coordination with our First Corps 62nd Medical Brigade colleagues, in addition to our Air Force, Navy, and community partners in the Puget Sound region.
With Army support and a long-standing relationship with the CDC, Madigan Laboratory rapidly established COVID-19 testing capability by standing up 4 separate molecular test systems early during the pandemic, testing our first patient on the 2nd of March. Madigan serves as the enterprise's only MHS Genesis high-throughput COVID-19 testing center, testing more than 34,000 Army, Navy, Air Force, Marine, and Coast Guard service members and DoD beneficiaries to date. We continue to expand testing capability by adding a 5th test system in the near future to provide even greater access to our patients during the upcoming influenza season.
During the COVID-19 pandemic, access for care underwent a massive shift to a mostly virtual online healthcare platform with face-to-face appointments reserved for urgent and emergent care. In addition, we leveraged the MHS Genesis patient portal, allowing a secure messaging environment to facilitate exchange of patient information, photos and videos, facilitating excellent patient care and patient education. Additionally, we leverage our existing telecritical care infrastructure for a novel application allowing remote patient-informed consent for clinical research trials, as well as facilitating patients and families visiting. Madigan has also been a leader in a collaborative research effort to create a national emergency telecritical care network to project our telecritical care assets forward for pandemic response.
Bed capacity was rapidly expanded in order to accommodate the anticipated influx of COVID-19 infected patients, thanks to the availability of excess beds at Naval Clinic Oak Harbor. Pharmacy operations were totally revamped by changing to drive-through only medication delivery. A large-scale drive-through testing facility was quickly established on the facility campus. In close concert with local county and state public health partners, Madigan Preventive Medicine rapidly implemented contact tracing to provide immediate response to COVID cases and prevent onward spread of the virus. Madigan Preventive Medicine, the Army's only preventive medicine teaching program, provided extensive public health support and consultation to senior warfighter and garrison leaders at JBLM, helping to navigate unprecedented challenges. This consultation was pivotal in successful implementation of unit and base-wide coronavirus lockdown and subsequent reopening efforts by implementing preventive measures while simultaneously enabling readiness and operational missions. Madigan's role in this pandemic was not limited to providing the highest quality care, evidence-based at JBLM. Our highly skilled clinical team of providers, nurses, and ancillary staff were also called upon to support responses as widespread as Seattle, New York, Texas, and Guam. As we move forward, we continue to meet the readiness requirement of our forces and are restoring healthcare capacity in a new normal environment. We deliver nearly as much care as we were prior to the onset of the COVID pandemic. However, now we deliver as much of that care in a virtual format as we do face-to-face, while maintaining the highest quality care. Further, Madigan personnel continue to actively support force readiness with virtual periodic health assessments, performing more than 1,000 PHs virtually since March. In order to protect our service members and our staff, high-volume soldier readiness processing was performed via telehealth. In addition, we harnessed our virtual critical care platform's capabilities to provide support of healthcare delivery critically ill patients throughout the Pacific Theater. Madigan's efforts have been clearly relevant to the global response from the outset. Our key role as primary investigators in a myriad of COVID-related research, including establishing the efficacy of convalescent plasma and the antiviral agent remdesivir, have yielded significant and impactful contributions to the management of this disease. In an effort emblematic of the innovative spirit of this organization, Madigan otolaryngologists, in a joint effort with Walter Reed, developed the COVID-19 Airway Management Isolation Chamber, or CAMIC, a device that minimizes healthcare workers' exposure to aerosolized particles during airway procedures. This invention, the only officially approved adjunct PPE device authorized by the FDA, has already been used in a variety of high-risk settings around the globe, including in theater during deployment operations.
Madigan Army Medical Center was ready at the start of the pandemic. We continue to be a local, regional, and international healthcare leader. Madigan staff remain ready, responsive, and relevant in their approach to the unprecedented demands of this pandemic. charged to ensure the medical readiness of the force on Joint Base Lewis McCool, maintain a ready medical force to respond, all while continuing to provide the safest and highest quality care to all of our patients. Madigan answered the call to contain SARS-CoV-2. Our healthcare delivery structures were reformed and reorganized to confront the pandemic. Madigan's responsiveness synchronized with Army Medicine, Puget Sound Military Health System partners from the Navy and Air Force, and with peer civilian hospitals and public health organizations at the local, state, and federal level. The COVID-19 response by Madigan demonstrates our commitment to engagement and collaboration, especially during the most uncertain days of the pandemic and the national shutdown earlier this year. We remain relevant and postured for the future with innovations such as virtual medicine, state-of-the-art diagnostics, and novel COVID-19 treatments. This is a new way, a reimagined way to deliver military medical readiness and exceptional care that we all associate with Madigan in order to meet and overcome the challenges of our time and beyond. Army Medicine, Army Strong.
Oh man, that was excellent. That was an excellent video, sir. Let's see, let me put it back on the regular area. Does everyone hear me? Oh, hold on. Let's stop the video real fast. Let's go back to it. Does everyone hear me? Okay, yes. Excellent. Sir, that was an excellent video, excellent presentation. As far as questions, etc., did you have any questions in mind or any other bits of information that you'd like to share with us?
Yeah, I think a lot of it's already been touched on, but the partnerships, I think leveraging those partnerships, and the one thing is it's really built dividends, allows us to build our relationship with our FORCECOM colleagues and our, including medical assets, but also First Corps and beyond. It's built partnerships with the Puget Sound between our Navy, Air Force, and Army colleagues, as well as the public health and community outreach. So I think it really cements our relationships with the surrounding community. The other thing that was touched on in the video was Genesis. So as the enterprise transitions to MHS Genesis, that presented some certain challenges, throughout this pandemic and with some of our processes. So for example, we're a referral testing center, and so it really makes it challenging if someone sends us testing or asks us for large-scale testing that is from a system that does not have MHS Genesis. It slows down the workflow, requires quite a bit of extra work, and so as we all transition, it will be infinitely easier if everybody's on MHS Genesis. And the other piece of that is the testing is much faster because of MHS Genesis, the way the computerized lab system works and the entry. So it eliminates a lot of needless administrative steps with MHS Genesis. The other thing I'd add is that we're in, I think, more of a sustainment phase of this. Clearly this is going to be going on for a long period of time. Some of the things that have already been mentioned include leveraging telehealth and looking for those platforms and technologies that will enable us to do that in an easier fashion with video capabilities that are secure. In addition, being able to utilize other pharmacy solutions. So how do we get folks to use Express Scripts, community pharmacies, while still delivering the benefits, sort of an all of the above approach to that as well. The other piece of this is, in terms of sustainment, is that you saw our tent facility. So we expanded from simply a drive-through testing capability at the emergency department. Clearly that wasn't sustainable. Set up a smaller tent area on our campus footprint, which has expanded a larger area. We're able to leverage COVID funding to be able to purchase a more sustainable trailer-like facility, so that we can have something that's more protective from the elements. As we move into the fall and the winter here in the Great Pacific Northwest, it's going to get rainier and colder, and having our folks out there and having the patients and the staff protected, I think, is also a very important aspect of this, and just understanding that this is going to be going on for some time, and being able to really change our workflows, change our resourcing, and our focus, so that we are able to sustain this effort in the long term while still providing for our patients. I mentioned labor and delivery. We still continue that mission. We have we're about up to 85% productivity of what we were pre-COVID in our operating room. So we are getting back to kind of a near normal patient care delivery system.
Excellent, excellent, sir. I think if you have any other comments or anything else that you'd like to share of the what y'all are doing up there in Madigan, you could share that at the end. We'd like to, I guess, move on to our final panelist. That would be Colonel Melissa Hoffman. How are you, ma'am?
Good morning. I'm great. How's everyone?
We're doing good. We're doing really good, ma'am. Thank you for joining us on this panel here, a first-time virtual AUSA, and we're looking forward to hearing what you've got to share down there at good old Fort Benning.
Absolutely, absolutely. Awesome to be here. Again, I'm Colonel Melissa Hoffman. I am the commander here at Martin Army Community Hospital here at Fort Benning. As mentioned, we are a community hospital, so a little bit different than the other 3 facilities that spoke earlier. We are one of the largest community hospitals in the Army. We do staff to 48 inpatient beds currently, with the capacity to expand, and I'll go into our expansion plan as we move forward with the slides. And we are on a TRADOC post, so a big part of what we do is provide care to a large trainee population. We're actually the largest basic training base in the Army, with up to 75,000 basic trainees and other types of trainees that come through Fort Benning every year. We also host the Army's highest risk training here at Fort Benning, which includes airborne air assault. We also have the Ranger Training Brigade here as well. In addition to that training mission, which again did continue throughout the pandemic and continues still, we do have a large active duty permanent party population. Of course, their family members, as well as a very robust retiree population here. The area is growing all the time. So about 82,000 beneficiaries that we took into consideration when we were building our pandemic plan. So I'm not sure if you have our slide deck.
Here we go.
All right, so next slide. Next slide. Okay, so some of the things that we took into consideration when we were formulating our plan, of course, the Southeast in general, in particular Georgia, and then especially Atlanta, was definitely designated as a hot spot for positive COVID cases. Fort Benning, we're situated about 80 to 90 miles southwest of Atlanta, so definitely in that catchment area of concern. So when we looked at our plan, we calculated a conservative case rate based off the data that we knew at the time, and of course looking at our population as well, as I mentioned, about 82,000 beneficiaries at risk. And then these planning factors allowed us to predict that we would exceed capacity potentially at day 60 from admission of our first COVID positive patient. You can see there too in the lower left some of the initial assumptions we incorporated into our planning process. Particularly that local facilities would be closed to transfers potentially because of the high volume of COVID cases that we were anticipating seeing. So we really looked internal at what we had on hand as far as our existing staff, Class 8, current equipment and infrastructure, really just looking at what we had internally as far as our initial expansion plan. Moving to the next slide. We used the standardized COVID staffing model to calculate our staffing required and used a phased approach to our expansion here, transitioning from that initial 48 beds in phase 1 to a potential maximum 440 beds in phase 4. Fortunately, we were very lucky to never have to move past phase 1 of our plan, but there is a trigger for each phase by meeting 85% capacity. before we would move to subsequently phase 2, 3, and then 4. Again, as mentioned by many of the other individuals on the panel, we did significantly decrease our services across many of our service lines to free up staff to flex, particularly to these inpatient areas. We did a lot of cross-training of our clinic staff, primarily focusing on those that had that med-surg, ICU, ER type experience first. As we flex them to the inpatient areas, a lot of that additional staff we flex to that external screening capacity outside the main hospital, as well as to our ER as well. Next slide, please. Moving to the next slide. There we go. Okay, you can see there, again, items that were needed as versus what we had on hand, looking at those critical pacing items in regards to those 4 phases of our expansion plan. This allowed us to identify decision points in which we would exceed either capability or capacity. And we determined as early as phase 3, actually probably phase 2 as well, that we could no longer meet capacity or capability demands. As early as phase 2, we would have exceeded our ventilator capability without some external augmentation, and also a significant strain on our personnel as well. Again, these subsequent slides really kind of move through our phases. You can see our triggers there, where we would house our COVID patients as we move through those phases. And I know we're running short on time, so moving through these slides, you can kind of see our expansion plan there in phase 1, and then moving into phase 2 and the subsequent phases.
Ma'am, we actually have no limit in the time that we could present, so take your time, feel free, and present the information. The people want it, so we're going to give it to them.
Okay. All right. Well, that's good to hear. Okay. Well, then moving back to the slides then. Okay, so for phase 1, as you can see, our first trigger for implementing the COVID expansion is when both of our negative pressure or isolation rooms in our ICU were occupied. During phase 1, we would consolidate all of our COVID patients on the ICU, which is a 8 physical bed ICU, and the medical surgical unit will absorb all other patients to include our non-COVID ICU level patients. So phase 1, we're segregating all of those ICU level, particularly COVID patients, into that ICU area, and then shuttling all the non-COVID patients to the medical surgical unit to include those ICU level patients that were not COVID positive. Moving on to the next slide. All right, during phase 2, we can expand our census to 92 patients, with all COVID patients housed on the 6th floor between both the ICU and the medical surgical unit. And then we would then shift all of our non-COVID patients down to our 2nd floor into our PACU area. And next slide, please. On the next slide, you'll see our phase 3 segregates all COVID patients on the medical surgical unit, the ICU, and the PACU. And this is then when we start to shuttle our non-COVID patients to our inpatient behavioral health unit and potentially our OR areas. So really filling up like every inpatient bed space that we had available to try to maximize capabilities and capacity here at the main hospital. So next slide, please. On the next slide, we move into our phase 4, and this is when we'd be looking at an external care facility. Beyond phase 3, really, we'd be maximizing all we had and really just throwing everything at the main hospital to try to sustain operations. At this point, we looked at our outpatient clinic areas and how we could repurpose them to accommodate low acuity level patients on gurneys, exam tables, and or stretchers. We'd be doubling up in our ICU area as well as our med-surg area, maximizing capacity there in our PACU and our ORs, and then trying to segregate that non-COVID population to our inpatient behavioral health area. We also looked at some external care facilities here. We actually had a group come down from the engineers. They contacted our senior mission commander, and they actually came and looked at some of the opportunities here on Fort Benning for an external care facility. So some of the areas we looked at were our current SRU barracks, as well as one of our large gyms here on post that we could set up similar to the Javits Center in New York City. They were really anticipating a large amount of inpatient COVID patients here across this entire area. So moving on to the next slide. This goes into our COVID testing and the capabilities that we have here. We currently have 2 Gen X 16 units that we use primarily for the majority of the testing that we do. Maximum testing capacity is about 480 to 624 tests per day that we can result on both of those machines. We also have 2 BioFire units. The BioFires are what we received initially around the beginning of April. Again, they can do 1 test per hour per machine, so not as efficient, but 48 tests per day. We've also utilized our network partners, particularly LabCorp, and then we have sent some samples up to DDMAC as well at Fort Gordon to use their Panther Fusion on a few occasions, and particularly when we've had a large influx of trainees throughout the summer surge. Some of the constraints we have faced primarily have been with our supplies, the Gen X supplies. They come on a week-to-week basis based on our estimated needs. So that's been a challenge. We've also had some challenges with our lab personnel as well. We've been historically short-staffed in our lab, so we've really pulled from a lot of our partnerships, the 14th Cache, and some of our other resources on post to staff up our lab and augment some of our other areas as well. Next slide, please. And again, this looks at all the testing we've completed here. Just under 15,000 tests that we've resulted all total. Majority of those have been done here in our lab. We've only sent about 5,800 out total to either LabCorp or DDMAC. 97% of those that have been tested have been active duty, to include trainees as well as our permanent party active duty. We currently have a 6% positive rate. We continue to keep a close eye on that. That has been downtrending over time, but with the upcoming holiday block leave, we anticipate that that positive rate may start to creep back up again. So pending any questions, that completes my information on our bed expansion plan as well as our COVID testing here at Martin Army and Fort Benning.
And ma'am, we actually do have 4 questions. The people have sent the questions, so we're looking forward to hearing your answers and response for it. So let me go ahead and put you on the solo screen really fast. And here's the first question, ma'am. The question is, due to limited staffing, how are you managing protocols during expansion?
As I mentioned, during the height of the pandemic, we did significantly reduce our services to only key and critical things that we had to do, to include a lot of those readiness services. As I mentioned, the trainees continue to come to Fort Benning. They continue to train, so we did continue to see some of those training injuries that we do normally see under normal circumstances. And then, of course, we had to provide care to those trainees. So a lot of our external clinics, those that are external to the main hospital, had to continue to function and provide that training care that they always do on a daily basis. As I mentioned earlier, we did cross-train individuals from a lot of those outpatient clinic areas initially focusing on those with previous significant inpatient critical care or emergency medicine type experiences. And we had a lot of good success there, and a lot of individuals that were willing to step up and move to those inpatient areas to support our bed expansion plan. Other staff we diverted to our external screening area. That was, again, outside the main hospital. We also had great support from our partners on Fort Benning, as I mentioned, on the clinical side in our lab and some of our clinical areas, but then also non-clinical personnel that really helped direct traffic and man some other key areas external to the main hospital, to include our external pharmacy services. Over.
Okay. Awesome. Thank you, ma'am. Next question. What is the current situation? How are you incorporating the local network partnerships?
Awesome. Great question. Thank you. We've currently essentially returned to our pre-COVID operations here. However, due to the training performed and the cross-training that was performed, and of course our internal plans, we could rapidly return to support an increased inpatient mission if we needed to. We did recently transfer here on Fort Benning from HPCon Charlie to HPCon Bravo. And we've just opened our schools here on post actually today. So we did maximize telework for a lot of our staff, and we still presently have about 25% of our staff that are out teleworking. We've also capitalized, as some of the other individuals have mentioned, on virtual health appointments. And that's been really helpful, as we've had some of our sections across the organization impacted by positive cases or exposure to those that have been positive. Again, as I mentioned earlier, the next decision point will be the number of cases that we may see after the planned holiday block leave, as we're anticipating about 15,000 individuals returning from holiday block leave, as well as initial basic trainees coming in that same week as well. So pending any further questions.
We've got two more. We've got two more questions, ma'am, and these are specifically just for you. And then after, I'm going to ask general questions that the entire population can answer as well. The next question, ma'am, is what could you outsource without reducing quality of service or care to your patients?
Outsourcing, being a community hospital, we do rely on those community partners for a lot of specialty care that we don't provide here, as well as that higher level of care that's provided at the medical center. But our local market in normal times remains fairly saturated. And then in particular with the COVID pandemic, there were definitely concerns with relying on the local community. Most of all, the specialty care that we rely on that comes from the local community was put on hold during the pandemic. And then we also saw a lot of those inpatient beds that normally stay above 90% filled become even more full as the pandemic hit. So then we started to expand our radius beyond the local Columbus area into Atlanta, Alabama, and as far as Macon, Georgia, where there's a level 1 trauma center. We also have great relationships, of course, with our military partners in the state, particularly DDMAC at Fort Gordon. We did send 3 patients to them throughout the pandemic process for that higher level of care, especially when our local market was saturated. As mentioned, we also explored ways to maximize our virtual health capabilities. And we found that a lot of our population has really bought into that, especially in our behavioral health arena.
So, and one more question, ma'am. The question is, what are the potential unintentional consequences that may occur during your plan? And how are you prepared to solve them?
Well, I think definitely one of the unintentional consequences is, the potential exposure of our teammates, our staff, to COVID, and then that potential loss of those staff to infection and quarantine. That was definitely something that we had to take into consideration when we were looking particularly at our expansion plan. We've been very fortunate that we've been able to partner, as I mentioned, with our senior mission commander, as well as some of the other entities on post that do have some medical assets to assist us. on the clinical side, and in particular, we received a lot of borrowed manpower that were non-clinical that really helped us as far as some of our external screening processes and our external pharmacy procedures as well.
Excellent. So, ma'am, I really appreciate you taking the time to share your answer to the questions that we had on screen. But now I've got some questions that I'd like to ask you all as senior medical military leaders in our Army. I obviously work with Recruiting Command. I help with the social media and public affairs and how we're trying to appeal to our future military medical specialists. My question, and it's one simple question that each person I'd like to have your answers on is, what is your why? Why do you still serve right now? And what are some words of advice you could offer for future medical professionals in our service? Who'd like to go first? All right, Colonel Wirt, you're up.
Well, you know, this is coming up over 30 years for me of total time in service, being initially a chemical officer on active duty and then transitioning to Army medicine. And I still serve because there is no place in my professional career as a neuroradiologist where I could do all the different things that the Army's let me do. I've been a brigade surgeon. I've got to jump out of aircraft. I've got to rappel out of helicopters. You know, I've gone and deployed to Afghanistan. I've had opportunities to do things that a normal radiologist would never have the opportunity to do. Been a department chief, and then been in different command roles. And you never get this type of opportunity in the civilian world. It would take me 30 years to become a department chief at a major academic medical center. And in this case, I could go back and forth between ForceCom to MedCom and experience such a wide variety of medical care, working with the highest level of professionals, our civilians, our military and joint services, our contractors, and just the wonderful esprit de corps that we have. It's a family, and it's an opportunity to serve and take care of people who go out and defend our nation. So it's the best job in the world, and I would do it again in a heartbeat.
Awesome. And let's get Colonel MALISH. I'll have you join on next. What is your why?
Yes, sir. No, thank you for that question. It's a great question, and I think my answer is going to sound a lot like Colonel Ward's. But just personally, when I was looking at med schools, I graduated from college. I knew I wanted to go to med school. I went to the Uniformed Services University, and I spent 2 days with those guys. And they blew me out of the water for a lot of reasons. Their approachability, their uniforms, quite frankly, their integrity, the way they carry themselves, the students there, was quite amazing. But really, my answer is very similar to Colonel Ward's. As a medical professional, looking for something to do in your life, where you're going to go forward, there isn't anything like the Army. Like I'm a cardiologist by trade, but I do a lot of other things. But as you're looking at med schools, you're looking at a career in which you become a cardiologist and spend the next 40 years out of your life doing cardiology. For recruits, if you wanted to do something different from that, if you wanted to be a cardiologist, a battalion surgeon, a brigade surgeon, a division surgeon, a cardiologist, you wanted to teach, you want to do policy like what I'm doing now, or command lane, you can do it all. And by the way, you're doing that while jumping out of airplanes and rappelling from helicopters, like Colonel Ward mentioned, having a very active, adventurous type of lifestyle. And on top of that, traveling, getting to see the world. So while I am patriotic, and a lot of the reason I joined was originally because I wanted to follow my father's footsteps. The reason that's really kept me in is just this variety, this lifestyle, these opportunities. It's just active, it's adventurous, it's wonderful. Now I'm getting a little bit older, I have to settle down, but that's the answer to your question.
It's all right, sir. It's all right. Colonel ROOFE, what is your why?
Yeah, I'm not going to shock you by saying anything too different than the other two speakers, but I'll tell you that, I'm over 25 years in the Army. I am an otolaryngologist by trade and a facial plastic surgeon, but it's a number of things. One is the collegiality and the sense of family, and that we're all in this together, and a sense of common purpose. The other is the sense of adventure that's just been mentioned. Did have the opportunity to jump out of airplanes, but I haven't done that since that I completed airborne school. But, just traveling around the world doing humanitarian missions. I've been all throughout Asia, deployed, traveled, done TDYs in a number of areas to get to know our folks. And then the opportunity to lead and mentor folks. I serve as the otolaryngology consultant. I've been a residency program director. I've served in a number of leadership positions within a variety of facilities throughout the inventory, and there's nothing like it. Just to have these opportunities, I could be somewhere just, I don't mean to minimize that, but I could just be, in a private practice somewhere, seeing patients day in and day out. But I think having the opportunity to mix that clinical with the leadership, the adventure, and the collegiality, all while taking care of the best patient population in the world is what's kept me in. Over.
Excellent. Ma'am, what is your why?
What is my why? Again, very similar to the previous gentleman. Definitely for me, the big, over these many years, I'm coming up on 29 years of active service. I am an Army nurse by training. So definitely that big focus on the entire team. The team approach in Army medicine, I think, has been huge for me as I've moved through the years. Initially came into the service through a scholarship. It was all about paying for school, and then of course that subsequent payback that followed that. But then just kept on staying and never looked back. Those leadership opportunities that became available, that ability to move up in the leadership realm, all the way to being the commander of my own hospital. It's just been amazing, and the wonderful opportunities for mentorship and leadership that have surrounded me and that have allowed me to get to this level. It's just been incredible. And then of course caring for the greatest population, America's sons and daughters. So what could be better than that? So it's been a pleasure, and I hate to see it come to an end here in the next year or so. But as I said, hit 20 and it was just never even paid attention, because I've just been fortunate to continue to be offered opportunities that have just allowed me to grow and progress. And it's just been a wonderful experience.
I think getting lost in taking care of others, where you're not thinking about the time of, oh man, this time and that time. It's a wonderful feeling. It's an enveloping feeling that just kind of gives you that extra push in the morning. Sometimes you may be a little sore when you wake up in the morning, but you still get up and you still execute to the best of your abilities. Team, I really appreciate everyone coming and joining our discussion. More than anything, the Surgeon General of the Army, Lieutenant General Dingle, thanks you all coming and joining us on this forum, sharing your wealth of knowledge, your expertise that you have. I want to implore to you all, share this podcast, because it's going to be shared on the Army Medicine YouTube pages and our Facebook pages. Share it away. Share it wide. Share it to anyone. Share it. It doesn't necessarily have to be someone AMED. You could share it to an infantryman. You could share it to an artilleryman, whoever it is that you want to share it with. Share this wealth of knowledge that we've got going on. Share the capabilities that we have in each of your medical facilities. And I just want to say thank you all for joining us today. Thank you. All righty. And you take care of yourself, and I will see you all later, sir.
Thank you. It was great.
No problem. And just to...
Thanks a lot.
No problem. No problem. Thank you all. And just to close on our discussion today, we had a great panel with 4 distinguished guests from various medical professionals, various hospital commands, and they've presented great information for us. If you're looking for more information, especially during these next couple days with the AUSA conference, check out our multiple places that we're sharing this information on. Go on, check out our Army Medicine site, check out our Facebook, check out our YouTube, check out our Twitter. check it out. Look up this information. We're out there trying to help you out today. And as we always say in closing, Army medicine is Army strong.